So thank you for being here for another machine learning Priberam seminar. Today we have João Santinha. He co-leads the digital surgery lab, and he's also an invited assistant professor at the Faculty of Medicine of the University of Lisbon. And he's a researcher in medical imaging, and he's here to talk about machine learning in imaging tests. So thank you so much for being here.
Thank you, Teresa. Thank you, everyone, for being here, and thank you, Priberam, for the invitation. So, as Teresa mentioned, I'm going to talk a bit about the machine learning in high-stakes medical imaging tasks, and this covers a bit of the work that I did in the PhD and with Professor Mário Figueiredo. Thank you for coming as well, and continues now with some projects that we have been doing. And hopefully this is going to be also relevant for those that are working in medical imaging, but also those that are not working in medical imaging. So medical imaging today is very important in medicine because whenever a patient goes into a hospital or a healthcare facility, is probably going to have an imaging of his body being taken, or even some blood sample, or histopathology slide from a biopsy. So we have medical images being acquired in terms of screening, diagnosis, treatment planning, treatments and interventions, but also the follow-up of patients. So throughout the journey of the patient, we have images being acquired, and images are very important because they allow us to probe the human body in a non-invasive way, and give us an idea of the anatomy of the patient, but also the physiology. And often physicians look at these images. They can be from different specialties. We can have cardiologists, radiologists, physicians of nuclear medicine looking at these images. And being humans, we know that humans have different levels of expertise that affect the reading and the output that we can get from these images. And they are also subject to stress and fatigue. So at the end of a shift, it's more likely that the human is going to make an error than at the beginning. If it's tired, didn't sleep well, if he's concerned about something, it is more probable that there is going to be some issues. This is becoming a bigger problem because currently our world population is growing and adults are living longer. So the times that they are going to visit an hospital would become more frequent and with higher occurrence. And in Europe alone, more than 1/3 of the adults have at least one chronic disease, and this chronic disease need follow-up, needs care, and this puts additional pressure into the healthcare systems, being it private or public. If this was not already too much, we are currently in Europe facing a shortage of 1.8 healthcare workers, and of the healthcare workers that currently are in the healthcare system, 40 of them are struggling with depression and anxiety, and 70% reported feeling burnt out. So naturally, we can understand that like AI is needed. AI is going to help them, and hopefully not to replace them. So most of you might know that Jeffrey Hinton back in 2016 that, well, deep learning is doing so much for images that it's obvious that we should stop training radiologists. In 5 years, it's going to beat any radiologist in their tasks. Well, predictions are easy to make, and in 2024 there was this meme about two different predictions, and the fact is that like in 2024, I would say that 2026 is still the same. Next year it's going to be the same, so we still have radiologists driving their regular cars to work. But nonetheless, AI can certainly help in different medical imaging tasks. So medical imaging is not just to look at the images and have a diagnosis. From the moment that we acquire an image, that we put the patient into a scanner, we start to have image processing tasks. And for these two, they are not often performed by humans. They are already performed by AI algorithms, machine learning algorithms. These three are often performed by radiologists. So for those online in Zoom, I was talking about pre-processing and reconstruction, denoising, and quality enhancement are already being making use of AI. The organ segmentation, lesion detection, and lesion segmentation and classification, we have some AI algorithms that do it, but most of the times humans do it because the segmentations and detections, the human naturally do it. The detection, the segmentation, it's something that takes a lot of time. So most of the times the radiologists detect a lesion, they try to classify it without needing to mark an image, and the monitoring is done normally visually and in a qualitative way, not so much a quantitative way. But prediction is something that the human has a very hard time to do. But AI can certainly bring value to that. And there are already use cases in the context of breast cancer where we have AI prediction models looking at mammograms and trying to predict the risk of a patient having cancer in 5 years. And this is going to be used to reduce the risk of these patients, as we do already for cardiovascular risk, where we give statins to the patients in order to reduce the risk of cardiovascular disease. So prediction is something that the human has a very hard time to do, but AI can certainly, or has been showing to be able to do. So the promise of AI in medical imaging is that we can automate quantification and start to assess the images quantitatively instead of just qualitatively that the human normally does do this quantification in a faster way, more reproducible. And even if it makes some mistakes, AI can also help correcting those mistakes. This is more in the context of whenever we have a segmentation, AI would certainly be able to use that, and we have several use cases to demonstrating that. So, as you may know, I'm preaching to those that already know this quite well. So we have different ways of doing machine learning, and we have the classical machine learning, which in radiology we call radiomics. So we delineate in an image a region of interest, which we call the process segmentation. And from that segmentation, that region of interest, we are going to quantify using computer vision methods, shape, intensity, and texture features. And then we have tabular data describing this region of interest for each patient, and we can apply the traditional machine learning methods to predict the outcome that we want. You also know deep learning, where we have features being learned to successfully perform the task desired. Segmentation can be part of the task that we want to perform, but one of the benefits is that if we want to classify a brain tumor as having a mutation or not, we often, or we might not need to rely on the segmentation. And we have been seeing models, deep learning models, achieving higher accuracy than traditional machine learning models, but the downside is that it requires lots of data. And this is one of the problems that we often face in medical imaging, and I would say in any healthcare domain, which is data availability and the associated problems that we have with that. So healthcare data is often not available in large quantities. Patients, at least in Europe, they own their data. Hospitals are the holders of that data, but whenever they need to share that data, they should get an informed consent of those patients. There are ways to circumvent that, but that always requires you to maintain the patient privacy. And that is something that not all of the institutions have the skills or the person power, let's call it like that, to do those ensuring the patient privacy. So removing all the patient identifiers, if it's a brain MRI, to deface it, because if we can reconstruct the 3D volume, we can see the face of the patient. So basically, we have restrictions on the availability of data. And this leads to one of the problems that we try to tackle with radiomics, with the community try to tackle with radiomics, which is we don't have the large amount of data to train a deep learning model. So let's go for the radiomics approach. But often we are dealing with this problem of having way more features than the number of patients, and this creates an issue. And it's always dependent on the radiomics, as a lot of knobs, a lot of different parameters that we can change. So we are faced with an issue of being highly dependent on the feature extraction, but also having this ill-defined problem of more features than patients. Additionally, one of the issues is that whenever we don't have lots of data from different hospitals, if we train in a single data from a single hospital, once we test on different hospitals that were not part of the training, we often see a decrease in performance of our models. So these end up having issues of generalizability. And here, just to show a bit what you can have from different hospitals, bringing images from the lumbar spine MRI, you can see the change in the contrast of the images, and this highly affects both the radiomic models, but also the deep learning models. So what then we often observe is that if we have a model, and this is for cardiac MRI, not from our study from our group, but a network trained in one single manufacturer, once it's applied to another data acquired in another manufacturer, you can clearly see that it stops performing well, this segmentation. And this is a big issue. And during my PhD, we started to deal with that. And one of the things that we started to explore was the invariance property of causal structures, both for engineering features and representations. So now we are going to try to move towards one step that we try to take to see if this could become a solution. It's still ongoing research, but we have some results from my PhD, but also like some after the PhD. So the issue is that we might still have and even have a diverse training data set comprising different acquisition parameters, different hospitals coming into this training data set. But the fact is that manufacturers are always producing new scanners, new sequences, and often we didn't observe the real world scenario where we have plenty of more acquisition settings and scanners. So we need to find ways of ensuring that these models will still be able to produce good results when they are faced with an acquisition setting or a scanner that it never saw before. So basically, and formalizing this a bit, if we have a training data set from a set of environments, we want to find a function that maps our covariates to our output. And we want that function to also be applicable to a domain test that has environments that were not part of the training. So, but this is easier to write here than to actually make it happen. One other thing that we need to understand is that whenever we look at causality, we have a cause that leads to an effect. And if we think about what the medical imaging is doing, it's actually looking at the biology or trying to get a grasp of the biology through an image. And if there is a change in biology, what we assume is that there is going to be a change somewhere of the image that can be a texture. This in the context of radiomics. So based on this and relying on the invariance property from causal structures, we started to explore this, and this was work developed taking a lot from the invariant causal predictors work from Jonas Peters, where back in 1943, this Nobel Prize of Economics defined that causal variables imply invariance. And Jonas Peters demonstrated that invariance can also imply causal structures. So we would, based on this, we would find a set of features that the P of y given the covariance of those subset of features would remain invariant across environments. So we did that for brain MRIs. We had the public data set comprising 4 different hospitals, and what our causal graph was like this. So we would assume that the IDH mutation of the patient would change a texture in the image, and we would try to use this method as a feature selection, assuming that we would have an environment affecting also the texture change, so the image. So this was, but we would try to predict on the anti-causal direction. And the results that we got were sort of a mix. Sorry. Okay, were sort of a mix, promising, but still some mixed results nonetheless. So we saw that. So what we did was always train with 3 centers and use the held-out center as a test. And we saw that for 2 scenarios, the performance between the 2 methods, for 1 scenario, it matched the first scenario. The third scenario was close. So in terms of sensitivity, was the same, but the specificity was slightly lower. But on the 4th scenario, it improved, where the traditional method would have a sensitivity of 0. But we still got one scenario where the test we tested with center 2 and trained with center 1, 3, and 4. We had for both models a very poor sensitivity. One of the things that was, at least for doctors, and in the context of interpretability of the models, even though they might not understand what these features actually mean, they always like to find models with a smaller number of features, and we can have arguments here, what is best, what is not. Not arguing with that and not expanding on that. But one of the things that we saw is that, like, using this ICP model, the invariant causal predictors models, as a feature selection, we were able to have models that would have sort of the same performance in some scenarios, but with approximately 1/4 to 1/5 of the number of features than the model without this feature selection method. So, as I mentioned, the prediction was going into the anti-causal direction. And one of the things that we also had in this data set was the gene expressions for these patients. So one of the things that we tried to see was, okay, can I sort of have a first feature selection method that relies on the finding an association between the gene expressions and each texture feature? And if I find a good association, I will keep this texture feature as a feature that might be associated with biology, with underlying biology. So we did that, and we found the set of features that we called biologically meaningful, and used those to feed our model, our regular machine learning models, logistic regression, random forest, you name it. And here we observed now an increase in performance across all centers for the proposed feature selection method. One of the things that we saw here was this strange behavior of having a perfect score, and we are taught that perfect scores are always sort of something that you should look with should look very carefully and should understand what is happening there, because it's very hard to have a perfect score. So one of the things that we understood is that test 4 was a subset, or they were from different hospitals, but they had just one scanner, and it was very similar to a subset of the scanners that Hospital 3 had. So this would justify that there was some kind of not true leakage of information, but this would justify that, like, this being a subset of 3, we would be able of sort of exposing some similar information to the fourth scenario. We didn't ended up, or we didn't conclude the experiments in the classical machine learning, but we wanted also to explore the context of deep learning. And we try to formulate how images might be represented with respect to the way that we use the annotation. So if an image is used to segment an organ, it's the imaging that is driving the output. But sometimes we want to predict something that is acquired by another test, and it's a biopsy or some kind of blood work. And this leads to different sort of causal models. So we have an image, and let's assume that this image is acquired in an environment, can be a scanner, but it's this image that is going to produce the segmentation model. So this is what we are going to do is try to create a model that from the image predicts our Y, and this would be something that goes in the causal direction. And here from this graph, what we have is that our function phi of I is independent or should be independent of the E, and that's what we want. So we want to sort of disentangle the image into different factors. If we go to the anti-causal direction, so let's imagine that we are trying to predict a mutation. So the mutation is likely going to cause something on the image. We would have this graph, and here, this graph, analyzing it, and what we have is phi of I is independent of our environment given our Y. And we use this to write down two sort of regularizers that we would put into classifiers. So adding them to our loss, and we would have two different then losses based on the causal direction of the prediction. So basically, there were L1 and L2 norms that we tested, and we would compute this whenever the environments would be different for the samples. And we tested this in a Wilds data set, so it's a benchmark that contains different data sets, and we tested that just for the images, and we had histopathology images, satellite images, and camera traps. And what we found was sort of a mix, but more recently, we understand why this might be happening. Doesn't mean that we will beat every score of this, but we understood that there was something missing in our loss. So we this got lower performance, but still was a good performance. We ended perform heavily on the satellite images, and the wildcam, we were able to improve over the leaderboard. And what was the case here that was missing, at least from our understanding now, is that whenever we have this regularizer, we were not having here that the features that were being learned were informative. So we believe that there should be also an entropy measurement of these features to ensure that there is no collapse of these features. And most likely in some of those cases, that was what happened. So this is something that we want to revisit, and we want to rework, just to explain that we are still taking advantage of these results and using it to further improve, and also like showcasing that sometimes we need to take some step backs, stop thinking about it, and then something appears and it clicks. But let's see. It doesn't mean that the results are going to be amazing. Continuing on that, and these were results from my PhD. And after my PhD, I wanted to keep working on this because this is something that I deal with every day. And this image I already showed, this graph I already showed, but here we are just formalizing it a bit different. So we have an image, we have a segmentation. The radiologist, what it does is it looks at the images, and the segmentation, it doesn't care so much at the intensities, and the scanners, whenever they change in a non-linear way. So we want to have this invariant prediction. And what we started working on was based on a result from the University of Duke. They were able to understand that these images, medical images, the MRIs, whenever they are acquired, they have metadata associated with them. So they have the pixel data and metadata. But if you strip these images of the metadata and you just give it the pixel data, they were able to have a classifier that would, from the pixel data, determine what was the manufacturer, what were the acquisition parameters from the pixel data. So means that the information, it's there, the information is very rich. And this sparked an idea of using denoising diffusion models, conditional denoising diffusion models, for us to create augmentations of this data. So these patients might be acquired in the GE scanner, and if I use them to train a model, most likely the model will not perform well on a Philips scanner. So one of the things that we wanted is, can we use denoising diffusion models to counterfactually simulate the acquisition with new parameters? And here we have examples. So these are the out of distribution data set for the test. And this is the ground truth. And we see how the model fails on the prediction column for those online. And we see that there are holes inside the breast where it should be filled according with the column that is noted true. So one of the things that we did was to, in the image space, so no latent diffusion models, a simple denoising diffusion probabilistic model, we would condition it on the imaging acquisition parameters. For those knowledgeable of, so we have manufacturer models. The main ones are Siemens, GE, Philips. We have different field strengths. Normally they are 1.5 or 3. This already changes quite a lot the images. We have different scan options, flip angles. These are acquisition parameters that will change again the intensities of these images. And we use this architecture now to counterfactually simulate the acquisition of a patient. So we would try to not to change the anatomy of the patient, but just the intensities. And we tried also to fool the classifier. So we would have an image that was acquired in GE with some specific parameters. After this, we would generate a counterfactual image with some specific AIPs, and we would be able to see if we fooled the image classifier, the image acquisition parameters. We did that when we had some interesting results that I'm not going to show today, but I'm going to show the results on the segmentation part. So this was not the fact that we didn't saw an improvement always when using the counterfactual. We saw it for some use cases. Some use cases we didn't saw it, but the sample size was also smaller. Again, the problem with data. But here we have the result of the prediction with the counterfactual augmentation, where you can see this improvement that happens once we, if these images are out of distribution and they are G, but this model was trained on Philips, once I do a prediction augmentation using the Philips counterfactual, I can see an improvement over my segmentation, a reduction on the holes that I have in panel on the right. So basically, this is some ongoing work now with latent diffusion and some more advanced methods. And also one part, because this is Priberam, and Priberam works a lot with text. In radiology, one of the things that we can also use is the radiological reports that are written by the radiologists, that are often written in this narrative form, which can be processed by NLP to extract this information to be used as AI labels. But often this is sort of hard to verify retrospectively for a large number of cases. And we have created at the Champalimau Foundation as a small example. In oncological settings, one of the things that we have is that we often have templates. So for staging different types of cancer, there is information that is required to be provided, and not changing the workflow of the radiologist and using speech to text and LLMs. What we have experimented was to allow the radiologist to do the reporting as they wish. So with the dictation system, they will dictate their findings, and then with the transcribed text, we can ask the LLM to structure this information. And what we see here is then the structure report, giving the information that was reported, but also something that is, for me, again, with this, is that if the radiologist forgot to mention some of the variables that are required, you will be able to detect. This is way harder to do. Of course, we can do this in the background and have a pop-up window telling the radiologist that you might have missed reporting some information. But in the background, we will need to have this information being done in order for us to detect that there was no reporting on the lymph nodes, and this is very important to guide surgery. So this is something that also allows us to create AI labels. So the processing of language that the radiologists have to do when they create a reporting is something that is meaningful also for medical imaging AI. And one of the things that I'm working, and this is a challenge for you to think, it's changing a bit the gears here, but there is this intervention paradox, prediction intervention paradox that we have been thinking about. And here, one of the things that you can think of is that there are two different types of models. Ones that are diagnostic and screening AI. So you have a disease, you have an image, and you do a prediction of this disease, but that doesn't change the disease status. But there are prognostic models that you are trying to predict future events. And this is where the prediction of the model can have an effect on the decision, on the treatment decision, and thus the outcome. So what this entails is that once you have retrospective data that you use to train this model, once you deploy it, you have this coming in, and all of a sudden, your performance metrics might be affected. So let's imagine the case of a patient with a high cardiovascular risk. So on the calibration plot, let's imagine that the model is very good. It would be situated over here. But all of a sudden, after the intervention, when we give statins to these patients, what I'm going to do is reduce the risk of this event taking place. So the event rate is going to lower. And what we see, if we monitor the performance of these models, all of a sudden our model has an apparent miscalibration. So how can we verify that the model is still working? So this is something that it is needed to solve. One possibility is to look for the event rate in high-risk patients before and after treatment, and as long as they are low with respect lower than the before deployment, this is something that can be used. But it's still an open problem, and it's a problem that we are now exploring and trying to formalize a bit more, because it's something that being AI models are considered medical devices, we need to ensure that the post-market surveillance can be done. So this is a sort of an open question. And with that, I conclude the presentation, and I would like to thank you for your attention.
Thank you so much, João.
Thank you.
Now we have time for 2 questions. Anyone?
Thank you so much, João. Very useful. So I have one question about the LLM, where you have the textual records. So are they matched with the images? So do you use both modalities?
So,
this is independent?
so when we did this, it was not matched with the imaging modalities. So we have the imaging modalities for every report, but this was a way for us to ensure that the radiologist would have a way to structure the report according with the guidelines without any burden. On the other hand, if they don't want the structured report, what we can have is always have this on the background being generated as an AI label, and to be then trained with pairs of images and these reports, and not have to go back to extract the information from here. Additionally, if the radiologist wants this information, what we can have is the thing done on the background, offer also a warning like there is this information missing. So for instance, a personal case, the mother of my wife was diagnosed with the breast cancer. So under the screening program, she had a lesion detected. They forgot to mention the laterality. So is it left or right? So this would pick it up already and could, even if it's this way or the other way, it would be able to warn or give some visual cue to the radiologist. And we would be able to collect data that in this format, it's more easy for us to train a model because it's already organized, it's verified, and it should be complete.
Understand if I got it right. So you have some model that structures the data with text data.
Mhm.
Can you also fill in this data from the images?
So we didn't do that. I saw recently some teams doing that. So they have tabular data, and whenever it's missing values in the tabular data, they go into the images. So it's a tabular vision model that tries to fill in this information.
Because in this case, if you have the images, you could potentially generate this report
Yeah.
from the images
Mhm.
and understand.
Yeah. Yeah, absolutely. Thank you, Manuel.
I just got a good question about the metadata. Like earlier at the denoising part, you said that you used some metadata for the denoising.
Oh, sorry.
The metadata used.
Sorry?
What is like the metadata or what? Like the metadata used when
Yeah. So the metadata that we used, this work has 2 parts. It has this denoising diffusion probabilistic model, but also has another classifier that, given the pixel data, tries to predict these parameters of the MRI acquisition. This is within the metadata of the images, but when we try to use this information or to train the classifier, we just provide the pixel data. And it's quite impressive because it's a regular ResNet 18 with all these outputs. So it's a multi-label, multi-regression. Some of them are discrete variables. Some of them are continuous. So there is this part of it. There is one here.
Hello, João. Thank you for the presentation. I also have a question kind of related to this subject, metadata in the pixel space. I think it was on the previous slide. You mentioned that the models are able to pick up from the pixel space, like which manufacturer of the scanner was used.
Mhm.
Right? So my question comes from like, you said one of the challenges when we are doing like segmentation or classification was that it doesn't really generalize across models when you use like all the data. But at the same time, the model is able to differentiate between manufacturers. So my question is, wouldn't having like more data, making sure that like wouldn't having more data enable the model to understand, okay, this pixel data comes from manufacturer A and this from B, but this isn't relevant for my classification task, so I can just kind of ignore this feature.
So yeah, that's a very good point, and that brings to something that I forgot to say. What we are trying to do here is then use this information to push the model to work like that. So it becomes invariant because now we have two views of the same patient. So for the classification, it should stop relying on something that like it's also contradictory, right? So only the anatomy would matter, not so much the intensities, because I have two views of a patient, and in one the intensities go this way, the others go this way, but the shape of the region still remains the same. So it's basically that what we are going to try to do. Yeah.
But I'm guessing this whole thing just comes purely from the fact that we do not have like enough data to be able to get to that point.
Yeah,
Right?
yeah, and also because we have in the future, our concern is not so much about saying that these images are from this scanner or from the other, is more that the model performs, and it's more like an adversarial approach. And the issue is that like you also don't know the future. The future is going to bring more scanners and more different parameters. And if you install a AI algorithm in your hospital, and if tomorrow something changes the scanner or the acquisition parameters, you still want the model to perform, because those changes are going to happen silently. And if the model is not good enough, the model starts to fail silently as well. We have a question here.
Thanks for the presentation.
Okay.
I was just wondering, at the beginning of your slides, you mentioned there is a prediction from mammograms to predict the ability of a patient relapsing, right?
Relapsing, in this case, it was like the patient doesn't have cancer, but there is a 5-year prediction that he has a high risk of developing cancer.
So I was curious about that. Can you elaborate a little bit more about that? Is that your work or?
No, it's someone else. I can, if we exchange contacts, I can point you to this. There are already some commercial applications where they are doing that at a 5-year risk. So
yeah, that would be
we can exchange. Yeah, welcome.
Okay, thank you.
Thank you. Thank you.